So good evening, everyone. This is Shagnik from ClearNet. ClearNet is very proud to be a part of this webinar as its digital partner. Now, before starting, I would like to play a short video of ClearNet. Thank you for all of your patience. As you all know, ClearNet is India's largest digital CME and doctor-generated medical content platform, which is exclusively free for all the medical practitioners. We are very grateful to the Indian Society of Gastroenterology Kerala and the star-studded panel with such highly affiliated doctors to be associated with us. Now, without further ado, I would like to hand over this session to Dr. Verghese Thomas. Sir, if you may proceed.
Thank you, Sagnik. Thank you
Welcome,
for
sir.
the wonderful introduction and for the support you are giving. And I hope you will be with us throughout our session.
Yes, sir.
And
Yes, I'm gonna
sometimes
be.
it may get a little delayed if the participants are asking a lot of questions. We may delay the closing for a while. So please be with us. And
Yes,
we hope
sir.
Jayantima may join at any moment. And there are some house rules. And Dr. Jerry, if you can do one thing. Some people may not be having the passcode. The passcode is the login ID is 862-2872-0081. I think that you can post the same ID which you got on your email in the PGClinics both group, because people may be taking time to go through their, they might not have registered, so it will take little time for them to get the login ID 862-2872-0081, and the passcode is 12345. Okay, and welcome to this year's first session. These sessions are conducted by ISGK PGClinics group under the auspices of ISGK Kerala chapter. We have similar program from Tamil Nadu, chaired by none other than Professor Jayantima from SRMC. These sessions are conducted once a week. The classes from Kerala are on Tuesdays at 8 p.m. and classes from Tamil Nadu are on the alternate Thursdays. So every week you'll be having a class, and we hope we'll be having class from the DNB on all Mondays, clinic case presentation. So by the end of these sessions, we hope all of you will be really good at case presentation, and our aim is to make you to present cases repeatedly in your center as well as in this program, so that you will get enough confidence to present. And the gym program is on, I think, first week of February at Hyderabad, and you also will be given opportunity to present cases, and grab the opportunity to present cases. So present cases whenever you have a chance, and be willing to be questioned by your teachers. Welcome, Jayanti ma'am. Happy New Year. Happy New Year to all of the participants. And I was just giving some introductory remarks until you joined.
Presenting today?
Yeah, Dr. Kiran Devanga from Lakeshore is presenting. He is presenting the approach to jaundice with the multiple case scenarios with some theoretical inputs in between. And Dr. Kiran Devanga is a senior resident in gastroenterology at Lakeshore. And today the faculty is Jayanti ma'am and myself will be moderating. Okay, can we start, ma'am? Okay, the house rule is that except the presenter and the moderators, all the people please keep your video and audio in the off mode. The video and audio in the off mode, because if you keep the audio on, there will be lots of disturbance and we don't want to affect the attention. Okay, with these words, I hand over to Jayanti ma'am. Can we start? I think she is offline. Dr. Kiran?
Yes, sir. Thanks.
Can't hear you. Sir, join.
Am I audible?
Kiran, we can't hear you.
Ma'am, am I audible, ma'am?
Can you hear me?
Yes, ma'am.
Can't hear you.
Okay. Jayanti ma'am, Dr. Saknik, please Mr. Saknik, can you check whether Jayanti ma'am is on a mode or something like that? From the host side. I will call Jayanti ma'am and ask.
Yeah, sir. I can check it, sir. She is on unmute mode only. Can you hear me, sir?
I can hear you.
Yeah. I can check it as she is on unmute mode only, but she is not audible. I am asking her to unmute, but also she is not able.
She is in mute mode.
I am just telling her
Jayanti
again to
ma'am,
unmute.
please unmute. You are in mute. You are actually in.
Right now, she on unmute.
No, because you are in a mute mode. Okay, now it's
Yeah,
okay.
now she is
Can you
unmute.
talk?
Ma'am, can you
Can you
please
hear me?
speak? Yeah, I
Yeah.
can hear you. Fine,
Yeah,
ma'am.
I can't hear Kiran.
Hello, ma'am. Can you hear me, ma'am?
Yeah, you are also audible. Fine, Kiran. I can hear you.
Ma'am, may I start, ma'am?
Jayanti ma'am, are you hearing?
I cannot hear
Not
Kiran.
me, not me or the phone, but others.
I-
Dr.
I'm
Kiran.
able to hear. I'm able to hear on the phone, but not on the.
Okay, can you just
Ma'am,
relog
can you
again?
please increase the sound of your laptop?
Yeah. One option is to increase the audio sound. Second option is to log
Or
off and relog in.
rejoin, ma'am. Right. Due to the
Let
some
it log off
technical
and come
problem.
back. You can hear me.
Yeah, log out and come back will be better because
Yeah,
that,
ma'am. We
You
can
can
hear
hear
you,
me,
ma'am.
no?
Yeah.
yeah. And also those who are attending the ISG National Conference at Jaipur this from Thursday onwards, please make sure that you attend the CME sessions because CME sessions are most useful. Lot of topics are covered in a span of a day's time. So please concentrate on that CME day and also all other discussions. Okay. Jayanti ma'am is still actively there. Can you hear me, ma'am? We'll wait for a while.
Are you speaking, Tanvir?
No,
Kiran?
We
Yes,
can hear you,
ma'am.
ma'am.
Actually,
We are waiting.
I'm not. I don't know whether others can hear. Others can hear.
Ma'am, I can hear you, ma'am. You are
Can't hear.
clearly audible to us.
Ma'am, is no, she must be connecting some audio devices.
And
Yeah,
log
if you
out
can.
and come back.
Okay.
Can the others hear?
We can hear you.
ma'am, can you hear me, ma'am?
No.
Ma'am, if you are Marcus here, if you are connected any devices to your computer, any audio devices like earphone or anything, please. But when you logged in, the logged in would have been using computer audio. Hmm? No. Hello. You are now mute. Can you unmute?
Yeah. Can you hear him?
Yeah, ma'am. You are audible,
can hear
ma'am.
you.
No. Can you hear him, the speaker? Kiran.
We cannot hear the speaker.
No,
Kiran?
that's what I'm saying.
So there is some audio. Can you, ma'am, can you do a favor? Can you log in from your mobile?
Okay.
Okay, thank you. Meeting ID is 862-2872-0081. 862-2872-0081. Passcode 12345.
Speak, doctor.
Ma'am, can you hear me, ma'am?
Continue. Something is wrong with my system. Just start off and continue. Don't worry.
Okay. Ma'am, what she can't hear. Okay.
If others can hear you, just continue. Yeah.
Okay, Dr. Kiran, please start.
Okay, sir. Good evening, ma'am. Good evening, sir. We'll be discussing a few cases which will be helpful for us to understand regarding the approach to the jaundice. Jaundice is basically derived from a French word, jaune, which means yellow in color. Jaundice is a condition characterized by a yellow discoloration of the skin, sclera, and a mucous membrane as a result of widespread tissue deposition of the pigment, that is bilirubin. So not all that's yellow is a jaundice. As you can see in the right hand corner of the slides, there is the patient is having the clear sparing of the sclera with a yellowish discoloration, whereas the skin is yellowish discoloration is seen. This is a classically seen in a pseudo jaundice, that is a hyperkeratonemia, which is seen in basically when a patient is having a more of hyperkeratin rich beta keratin rich foods like carrots and this one, which is mainly seen in the western countries. So clinical jaundice is basically seen when the bilirubin level in the blood is more than 3 milligram per deciliter. As we know, it is classified into prehepatic, hepatic, and cholestatic. Prehepatic due to the increased bilirubin load causing because of the hemolysis, and hepatic is basically because of a decreased conjugation or because of the transport defect. Cholestatic can be intrahepatic or extrahepatic based on where is the obstruction in the bile flow. So coming to the first case, where a 16-year-old male patient presented with a history of easy fatigability for 3 months, yellowish discoloration of the eyes since 1 month. There was no history of any abdominal pain, fever, pruritus, or clay-colored stools. The patient clearly denies any change in the urine color. So here we are basically, before going into the history, we should know whether unconjugated bilirubin is basically albumin bound and it is water insoluble. Hence, it is not excreted in the urine, whereas the conjugated bilirubin is basically water soluble and it is excreted in the renal excretion.
Dr. Kiran,
yes, sir.
Tell us what you are thinking about that particular scenario and then explain it.
In this patient, sir, basically patient is
go back to slide.
In this patient, sir, patient denies the patient is a 16-year-old boy who presented with a history of a jaundice, but there is a urine color is not having any change in the color. That indicates that a patient is suffering from a hyperbilirubinemia, but it is an indirect hyperbilirubinemia.
I'll just put it across like this. This actually we had this in ward rounds. This is typical case of ward rounds.
Yes, sir.
So I just put it across like this. A 21-year-old boy just says, I have jaundice and comes to the OP. What is your approach? He says, I have got jaundice.
If a patient, ma'am, depending on
he says, I have jaundice. Okay, so how would you approach?
Depending on the first thing, ma'am, whether the patient might be having a hyper unconjugated or
no. History. Patient is coming to the OP saying that he says, doctor, I've come to you, I have got jaundice.
What are the set of questions you will ask him
when
somebody comes to you with jaundice? That's all.
This is a typical ward round case we had in 2 centers.
We need to ask for a patient whether patient is having a history of any fever, or any fatigue.
I've got jaundice for last 5 years.
Is it associated with any pruritus, or is it associated with any
5 years jaundice, doctor? Which type of jaundice? This is how it will go. By the way, okay. 5 years jaundice. When can you get pruritus for 5 years?
In progressive familial intrahepatic cholestasis, there might be.
You think it is familial? This particular patient, 21-year-old, gives history of jaundice, and he will have pruritus for 5 years in familial. They'll have for 5 years. He'll have.
Kiran, the way to think is, what is the most common cause of jaundice in a youngster, which is going on for 5 years without much problems? When you see the patient in the OP,
familial jaundice will be present. They will present.
I think
others don't answer. Okay, please don't answer on the chat box, please.
Like Gilbert syndrome and the Dubin-Johnson's, they will present usually with the jaundice, sir, but without any asymptomatic jaundice, basically.
Again, Dubin-Johnson. Be very careful. What you see most commonly in the ward, that is what you have to say.
Gilbert is the most commonly seen familial type. And one of
what
the
else?
The hemolytic anemia is another differentials which we have to keep in the young patient.
Yeah, this is how we'll approach. No, this is how we'll approach. Now what else can be there? Patient says, I've got jaundice. What is the other connotation? The other one is HbA positivity. They come with a different meaning. Okay. They will come to you saying, I have jaundice. This is a classical ward round we took this time. Patient says, I've got jaundice for 5 years. So now what are the common causes that come to your mind? And now tell what questions you'll ask in such a situation to come to a reasonable diagnosis on a clinical basis. And then you discuss your case. Then it's easy.
If you are suspecting a hemolytic anemia.
Not you are suspecting. You are the person seeing the patient in the outpatient clinic. Patient has come to with jaundice for 5 years. What questions will you ask so that you come to a reasonable diagnosis in your mind?
We need to.
What are the questions you ask?
History of anemia or a blood transfusion history is there, or any frequent history.
Why should you ask for transfusion?
One of the main reason is to rule out a hemolytic anemia. Hemolytic anemias might be having a frequent blood transfusion history, and those who have if the hepatitis B also, the risk of transmission is high in patient.
So they present with jaundice for 5 years, HbA positive present with jaundice for 5 years. This is exactly what happens in the exam. It's a classical way of presenting. Now you approach and then you give your talk. So number 1, what questions will you ask for hemolytic anemia? Come on.
Hemolytic anemia, constitutional.
What are the common cause of hemolytic anemia, and what are the important symptoms that you will ask?
In hereditary spherocytosis.
No, we're not asking the conditions. That is in your mind. What questions will you ask?
The patient might be having an abdominal pain, ma'am, repeated abdominal pain. That might be the one of the thing.
Most common. Fatigue.
Fatigue. Easy fatigability is the most common cause.
Fatigue, exhaustion, asthenia, tiredness, and some fellow will say that your eyes are yellow. Then the next question you'll ask is your urine high colored? You were about to discuss the same case you're presenting. I'm putting in a different format.
Yeah.
What will be the urine color?
Urine color will be normal in case of
Exactly. So that's the first question that you'll ask. That's the first question that you'll ask. You'll ask for fatigue. Yesterday you want to go to hemolytic, and you'll ask this. Then you said about abdominal pain. Why did you ask for abdominal pain?
In sickle cell anemia, they will have abdominal pain, ma'am, and even a cholelithiasis because of a repeated hemolytic
Exactly.
anemia.
So what else will you ask? You want further confirmation. History of splenectomy, history of polycystectomy, history of polycystectomy. These are the questions. Family history of anemia. There are belts, there are focus belts in the country where you have hemolytic anemia. The Coimbatore belt we have, around Coimbatore, we have hereditary spherocytosis. Thal minor is quite common in several parts of the southern parts of the country. Now, so this is one hemolytic. Then we'll see what examination. How will you now, what are the other causes? So you've got hemolytic, and then what's the other?
The other possibility in this, if a patient is having urine discoloration, normal urine color, the Gilbert is another possibility.
So what questions will you ask Gilbert?
Gilbert's usually presents without a symptoms.
It will be safer to say congenital hyperbilirubinemia. But then there is a chance that they will ask what are the types. So like that, you fill up your time rather than directly going and saying Gilbert. Agreed, Gilbert is the most common congenital hyperbilirubinemia you see in the community. But the way in which you answer, you invite questions which you know, and then gradually take the conclusion. Okay.
Okay.
Okay, go ahead.
Now tell, what questions will you ask for Gilbert?
Sir, Gilbert, actually, family history of a Gilbert is one of the
Nothing. What percentage? None of the patient will have a family history. Although it's all nothing. They will say my grandfather. No one knows.
The previous.
What is the most important thing? What are the common things in Gilbert? They will say a friend noticed. Patient does not notice jaundice. Around the age of 19, 20, 21, when they go to the college, even the parents don't notice it. It's only the friends who notice that there's some yellow color in your eyes. And then the patient goes for investigation. And then what else will you ask? Then you'll ask, he's educated, what is the average level? Then he will say it's around 3 to 5. What else will you ask beyond that now? He says it is around 3 to 5, which is 1.8. It is never normal. It's always 2, 1.8. What else will you ask then? What are the things that will enhance the jaundice?
Like any infections, the viral infections?
Not infection, no. Exercise. Fasting. Exercise. These are the ones, because we do what's called as a calorie deprivation test. Okay, there's a test called calorie deprivation test. There's an IV nicotinic acid test. Though we don't do that, but they will say when I'm fasting, I find the eyes have become yellow. It occurs deeper. Otherwise, the urine color is normal. Otherwise, I'm okay. So you'll exclude by saying no fatigue, no run. Now, which is the other congenital hyperbilirubinemia, where the patient will say, I've got jaundice for several years.
Krigler-Najjar is seen basically in the younger age.
No, I'm not. I asked you, what is the next one? See, the exam there, I'm trying to behave just like an examiner. Okay, this is exactly what happens in the examination hall. You said, Gilbert, we've discussed that. What any other differentials you have? Patient says, I've got jaundice 2-3 years. Which is other congenital hyperbilirubinemia.
Dubin-Johnson's can present, ma'am.
How will they present?
They will present with a conjugated hyperbilirubinemia with
Doctor, I just want to tell you this conjugated and all is only after investigation. We are still in the clinical. We are still in the
high-color urine. They will present with a jaundice with a high-colored urine.
Yeah. What else will you ask? So when can you get a jaundice with high-colored urine, and otherwise the patient is normal? One is Dubin-Johnson.
And another one is Roters can present with like this.
Rotor. So any difference you can have between Rotor and Dubin-Johnson clinically?
Clinically,
what will be the urine in Rotor versus Dubin-Johnson? What happens to MRP2 in Rotor versus what happens in Dubin-Johnson?
Dubin-Johnson MRP2 is defective, ma'am.
Defective. What happens in Rotor?
Rotor OAT is defective, ma'am.
What is MRP2 in Rotor?
MRP2 is a basolateral membrane.
Sorry, Baba, what is it normal or abnormal?
Abnormal. Dubin-Johnson, it will be abnormal.
In rotor, I'm asking you.
Rotor, it will be normal, ma'am.
Then what will happen to the color of the urine?
Color of the urine will be normal, whereas
Normal, exactly. So here you have jaundice, which is deeper, which will be deeper than Gilbert.
Yes.
It will be 5 to 7. It's deeper because it's predominantly conjugated. But the urine color is the one that makes a difference in Dubin-Johnson versus Rota. See, this is the way the exams are conducted. After this, they'll ask, how will you go for investigations? What is it? After this only. This is a patient who's got 5 years jaundice, and he comes with a huge bundle of reports and he shows it to you. And this is how you have to think in your mind. When a patient comes to the OP, what are the differentials that you will offer at the outpatient? And then comes your open up your examination first, and then investigations. All right.
Okay.
Dr. Viti?
Yeah, let him continue.
Now you continue.
We were discussing regarding unconjugated bilirubin, where it is basically a water insoluble.
What I discussed is a typical wardroom case. Okay.
Okay. This is unconjugated bilirubinemia results in more of a normal urine color, whereas because conjugated bilirubin is excreted in the urine, it will cause a dark urine color. So this is a case where patient is present with a jaundice and unconjugated the normal urine color. It is basically unconjugated hyperbilirubinemia. So two major important things to be differentiated is one is hemolysis, which is because of increased load of bilirubin arriving at the liver, and the second one is a Gilbert, which is because Gilbert bar Krigler-Najar, which is because of diminished hepatic capacity of conjugation of the bilirubin. So if we differentiate between these two familial conjugate hyperbilirubinemia, the type 1 and type 2 is basically seen in the young age. Type 1 is seen in the neonate, whereas type 2 is seen in the first decade of a life.
In a given patient, when will you suspect Krigler-Najar?
In a patient.
So the pediatric age group is not going to come to you. Type 1.
Yes, ma'am.
No. What will be the presentation of type 2?
Type 2, they usually respond to the phenobarbital.
That's all treatment, no? That's again treatment. The bilirubin will be 20, 21, 17, and the direct will be just 1.2, 2.1.
Ma'am, actually, when compared to the Gilberts, it is the bilirubin will be high in case of a type 2 when compared to the Gilberts.
Exactly.
Less than 5, ma'am.
Exactly. So therefore, the bilirubin will be much more there, but clinically you cannot differentiate. But the reports will tell you that it's Krigler-Najar type 2 or it is Gilbert's. Exactly. So the enzyme defect is UGT1A1. In one it is complete or more, and the other one is partially less.
Partially less.
Any of the drugs that can affect UGT1A1. Name the drugs that can affect UGT1A1. And in the ward they call you and they say the bilirubin is 21 and the direct is 1.2. Irinotecan.
So,
and then heart treatment. No, atazanavir.
Yes, ma'am, atazanavir.
Yeah, all these drugs. So antiviral drugs, retroviral infection drugs, irinotecan, and there's one more drug. All these influence the UGT1A1. And you can have a rocket high increase in indirect hyperbilirubinemia. The differential will be Krigler-Najar type 2.
Okay.
Now you proceed.
So between the difference, all will have a difference UGT1A deficiency, but the main thing is in the Gilberts, it is basically a promoter gene defect, whereas in the Krigler-Najar 1 and 2, it is basically a axonal defect. So here is a patient of 16-year-old with a jaundice and a normal urine color and a easy fatigability, which is a constitutional symptom. In this patient, I would like to exclude two things. One is Krigler-Najar 1 and 2, where my possibility will be hemolytic anemia and the Gilberts. However, patient is having a easy fatigability and constitutional symptoms. So hemolytic anemia is one of the possibility which I want to keep before going into examination. On examination, patient had a pallor, icterus was present, no scratch marks. Systemic examination only showed a mild splenomegaly. These are the investigation which the patient had. The CBC was showing a 7.9 of a hemoglobin. LFT is MCHC is 38 and LDH was 925. And LFT showed a mild increase in the indirect bilirubinemia. That is total bilirubin of 4.2 and indirect is 3.8. And peripheral showed up smear showed a features of reticulocyte count of 4.8 and reduced RBC counts were there and spirocytes were present.
No, hold on. How did they count? Usually, reticulocyte count is done as a separate test. So first smear, they look for anisopoikilocytosis, erythroblasts, etc. Reticulocyte count is usually done as a separate test.
Yes.
And usually reduced RBC counts are not a feature of hemolytic disease unless there is an acute hemolytic crisis. Normally there will be hypercellular marrow, and in fact there will be lot of immature reticulocytes, erythroblasts, etc. in the blood. Okay, so reduced RBC count may occur in an acute hemolytic crisis just after the hemolysis, and generally it is more of a neoplastic anemia picture. So then first smear generally shows anisopoikilocytosis, teardrop cells, erythroblast, larger RBCs, and of course, depending upon the specific condition, you may find spirocytes, you may find thalassemia type of cells, sickle cells, sometimes all these things. Okay.
Yes, sir. And
because most of your examiners are very good at general medicine, and the moment you seem to be making a mistake in those lines, they'll immediately catch you, and it may not really affect your examination, but still you can feel upset during the discussion.
That MCH is grams per deciliter.
Ma'am, which one, ma'am?
MCHC?
That is by mistake.
It's percentage, no?
Yes, ma'am. It's by mistake. It's.
I think the units given are wrong. Okay.
Yeah, unit is wrong.
MCH. Okay. You have to be very sharp on these things. Okay. Because they will catch you on all these things. Examiners are very sharp and they are seasoned people and they know the general medicine very well. So
what is corrected? What is corrected count?
That is, ma'am, reticulocyte count with the hemoglobin. We have to correct, ma'am. RBC count with the RBC count, ma'am.
Yeah, how do you do it?
The correct reticulocyte.
All this you should know. Okay.
Okay.
All this you should know. Corrected retic count, peripheral smear in liver disease, all the descriptions. Would you do a Coombs test? What is Coombs test? It can just go on like that. So how should you manage this patient?
This is, ma'am.
How do you manage this patient? How do you manage?
What's the treatment for his illness?
Spirocytosis basically the spleen, ma'am. If there is a hypersplenism, is the one of the reasons.
Hypersplenism
means.
Okay, you have to come to the point. Don't go around and around.
I told you the history. What questions you'll ask? I told you what questions you'll ask.
The splenectomy is.
Splenectomy with cholecystectomy.
Cholecystectomy.
Yeah, that you have to say because there's already gallstones and he has spleen and hemolytic disease. Okay, significant anemia. Treatment is splenectomy. And of course, when there are gallstones, you have to take care of that also. Okay. We'll go to the next. Do we have? I think I will. Revanga can present, but I think another person can. Sham. Another person can discuss the case. Okay.
We'll start. Coming to the second case, a 28-year-old male residing in the hostel presented with a history of yellowish discoloration of the eyes and urine since 1 week. This was preceded.
Just stop there. So what questions?
Dr. Shumuk?
Yeah.
Dr. Shumuk from Tripulam, Chennai, are you there?
Yes, sir.
Yeah. Okay, what questions will you ask? Patient is from IIT, gives history of jaundice for 5 days, 1 week, yellow discoloration of eyes, and high colored urine. What questions will you ask?
This is acute onset of jaundice since 1 week.
Just keep telling what questions you'll ask. See, all that is in your mind, no? The patient is in the outpatient clinic. He says, I've got jaundice for 1 week.
Yeah. Preceding history of fever, nausea, vomiting.
So one is prodromal. Symptoms.
Yes, ma'am. Prodromal symptoms we'll ask, and we'll ask
from the prodromal symptoms, can you differentiate the various types of hepatitis?
From the Prodromal symptoms.
Yeah, what
So
are the
you saw-
usual prodromal symptoms? Then tell us which is for which.
This is also Viva question.
What's the most common prodromal symptom with which they come in acute hepatitis?
Fatigue.
Okay.
Fatigue. Fatigue is not the
Okay. One. Then
Fatigue and malaise.
fatigue, malaise, agreed. Then
Nausea.
okay. Nausea. GH is nausea, vomiting. Okay.
Dr.
Fever.
Vishnu, switch off your video. You're relaxing, you know. We're all sitting upright here. Switch off your video and you can relax. Yeah.
Yes, ma'am.
Anorexia, nausea, vomiting, fever. These are the questions that you'll ask. No? Anorexia, nausea, vomiting, fever. And for hepatitis B, you get arthralgia, serum sickness like presentation. That's it.
Yes, ma'am.
More of body and body ache,
Body.
myalgia, arthralgia. Those will be more in favor of
Hepatitis B.
Yeah.
Yes, ma'am.
Okay.
Next, prodromal. Next question.
Next, we'll ask if there is history of abdominal pain, pruritus.
No. We don't go to jaundice. Any other thing that can cause this 5 days jaundice? Patient has come to with jaundice for 7 days. What are the one is prodromal? What are the other causes that can cause this jaundice? Alcohol, drug induced, everything you have to keep in mind. No, we do not know what the case is.
Yes.
There's a history of jaundice for 1 week. So first and foremost, that's why the history, that's why it's important. You will say antedating the onset of jaundice, patient gives history of prodromal symptoms, or he's been consuming alcohol, or you say he's been on medication for, say, tuberculosis, whatever it is. Then
Yes,
only you start with the various things related to the jaundice. There are
Yes,
3 common causes. No, the 3 common causes of jaundice would be viral hepatitis, alcohol, and DILI. No, they're the ones that precipitate, which has a preceding history.
Yes, ma'am.
If there is no preceding history, it is obstructive jaundice. So you can almost be 100% right on that. If the patient has got jaundice sudden onset for 5 days and none of these 3 are there, 99% of chances are the patient has got a cholestatic jaundice or extrahepatic cause.
Yes, ma'am.
Now start. What else you want to ask?
Then associated jaundice, if it is associated with abdominal pain, pruritus, and platelet stools.
Okay, what is the relevance of abdominal pain?
Pain or discomfort? Or pain? Pain.
Abdominal pain.
Yeah, in viral hepatitis, it may not be severe pain. It may be upper abdominal discomfort. Some persons may complain of pain due to acute distension of the capsule due to hepatomegaly. But mostly, pain is generally not a dominant feature of acute viral hepatitis. It's a discomfort. So, which are the situation you get jaundice of 1 week and pain?
Just we'll ask to rule out extrahepatic cause for jaundice.
Okay, like choledocholithiasis,
Choledocholitis.
Yeah.
If patient is having previous history of biliary surgeries, to rule out post-op biliary strictures. Then
only 2 questions you ask, doctor: pain and fever. When the patient's got pain, ask for fever with chills.
Yes,
if they are present, likely to be extrahepatic. If they're absent, it does not negate the possibility of extrahepatic biliary obstruction. Very simple.
Yes.
Okay. Yeah.
Yes, ma'am.
Yeah. Continue.
Okay. Okay, continue. Revankar, your slides.
So here, patient is presenting with a prodrome before the evidence of before the episode of a jaundice. So the likelihood is a viral hepatitis, which is A, B, or E. So as we know, the hepatitis A usually starts with an incubation period of 2 to 4 weeks, and then there will be a prodrome, and after which the patient will.
Just 1 second. Just 1 second. What questions will you ask for A, E, A and E?
Ma'am,
not you, the other person who was present. The patient is from IIT. What questions will you ask for A and E? He's 24, 25 years old.
Consumption of food outside food consumption.
More than that, outside, everyone is eating outside. What are the types of E infection you can get? What are the types of E infection you can get? What is sporadic, epidemic, epidemic and endemic? Someone is just talking on that. I'm getting fed up.
No, everybody is mute actually.
There's no one in my house who's talking. What is sporadic, endemic, and epidemic? HEV. Have you heard of epidemics of E?
Sumuk, are you there? Sumuk. Revenga.
Sir, in the endemic, basically, one particular region will already have that disease, and it is not a surprise. In the epidemic, it is basically in one area where it was not already a disease was available was there, and there is a sudden rise of the.
Where have the epidemics in India occurred in HEV?
I'm not sure, ma'am.
You heard Dr. Kuru's name?
Yes, ma'am. It's hepatitis E who discovered hepatitis.
Where? Which part of India?
From I think Punjab, Chandigarh. I'm not sure.
You all know only the tertiary representatives.
I'm not sure, ma'am.
Kashmir.
Kashmir.
So the history is like this. In 1970s or 1960s or so, there was a huge jaundice in Delhi. They stored all the samples, in the freezer. And then Kuru found that there was an epidemic of HEV in Kashmir, Shere Kashmir. And then the people in Delhi took out it was called as non-A, non-B sample. They called it as non-A, non-B. And then they analyzed after he mentioned about the HEV. I'm getting fed up with all these people talking.
There is a lot of crosstalk. Hari Krishnan, can you mute?
Sorry.
Okay.
And then when they studied the sample, it was actually HEV. So the earliest description actually is in Delhi, but they got into the testing after the description by. And then the third epidemic was around Kanpur, when Dr. S.R. Naik and Dr. Rakesh Agarwal did a huge study. And then they found that HE was present. This is epidemic. When it's endemic, it is like an IIT. Suppose you have one common, so these are the simple questions that they ask. If there's a water tank and the water comes to a particular street, then all the people in that street will get, because it's a contamination of the sewage water. This will be endemic, and it will just be in that pocket. So in Chennai, we have, CRPF, there's a heavy vehicle factory in Navadi. Around December, we'll get about 10 or 15 cases. IIT will get about at least 10 or these are all. Sporadic is just one and one. One occasional case that you get. You must know all this, because HEV is being described in India. What is epidemic? And you get cases from Kerala. Few endemic pockets are there in Kerala, you get HEV. What about A? This is a patient who's adult, no?
Yes, ma'am, 28-year-old.
No, the other person. When will you suspect A in an adult?
Why is hepatitis A uncommon in adults, grown-up adults, or middle-aged people?
So,
I think he's not there.
So actually in adults, means grown-ups above 50, grown-up adults, they will have antibodies against the.
They would have been exposed and they would have developed
subclinical jaundice.
Okay, so the most susceptible are young children, adolescents, young adults. Okay, and when they usually present with the jaundice? Nowadays, the earlier pattern was that in India, during the toddler period itself, they used to get jaundice. Now the pattern has changed. Now, which age group seems to be affected with this hepatitis A, if at all they have hepatitis A?
When they are shifting to the hostel.
Yeah, when they
go second decade.
Yeah, That is when they go for, once they finish their school, till then they are with parents mostly, with parents and under tight control, eating from outside and all is usually restricted. Once they are in the hostel, they are free to go out and eat. Okay. And generally in most of the residential hostels, the water source is also equally bad. And we have seen very often many residential institutions, there's outbreaks of hepatitis due to contaminated water. Okay. Which is when they are young adults.
Maybe the history will be like this. Other members of the family, you have to ask. So I always ask, any other member in the village had the jaundice? The same street was a jaundice, then it is E. It has to be E. You can almost pinpoint the history, but the history can pinpoint and say this is likely to be E. Okay?
Yeah. This is called a social clustering, familial clustering. Okay. As for familial clustering of illness, social clustering of illness, that's in the neighborhood. Okay. Sometimes people attend feasts and etc. marriage functions, and if the water is contaminated, large number of people may be affected fairly in the short period of time. Okay.
Yeah.
Such history is also very relevant. Okay, can we proceed?
Now move on. Now move on.
Yeah, in this patient, we need to ask regarding a social or household social clustering because specifically in the A and E and B, specifically if parents are having a hepatitis B, their chances of the child having a hepatitis B is also high likely. History of a drug in consumption and any CAM or ethanol usage, and history of any abdominal pain, specifically if the hepatitis we are concerning, then it is more of a dull aching type of pain will be there, and if it is a veno-occlusive disorders, patient will have a presence with ascites, abdominal distension, and the right-sided abdominal pain. So feature family history.
What about B? Adult B. How did you suspect adult B? What history will tell you it's adult B?
The blood history of any blood transfusion or any the high risk section.
When transfusion 5 years back?
Before 2000, ma'am. When before that there was
acute hepatitis B. What questions will you ask by acute hepatitis B?
History of one is history of a blood transfusion, ma'am. Second is
when
that is before the screening of hepatitis B. That is before 2000.
You're talking of C, doctor, 1990. You're talking of C. We're not talking of C. I'm talking of B. But then what's the incubation period for B?
Okay.
What is the incubation period for B? 50 to 150 days.
Okay.
So any transfusion ahead within 50 to 150 days, any surgery, any dental, those are the things that you did. What we generally say is, according to Dr. Sareen, every acute hepatitis B is reactivation, according to him. But nothing prevents the person from having a de novo acute hepatitis B in blood. So you'll have to ask, what are the things within the incubation period? Supposing he says, yes, I had transfusion just about 3 weeks back or 2 months back, which is within the 50 to 150 days, then the chance of this patient having B will be there. Then they'll have all the prodromal symptoms of a B.
Okay.
In such a patient, you will not suspect veno-occlusive disorder and all. They'll have ascites. This group, the last group that you said, they will have the chief complaint of abdominal distension.
With abdominal pain and abdominal distension, ma'am. Yes.
Yeah, so here you're discovering only a patient with jaundice who's come to the clinic with some abdominal discomfort, no pruritus. Okay, continue.
Okay. So these are the few differentials when acute or subacute hepatocellular injury is there. That's a viral hepatitis, basically A, B, and G. Toxic ethanol, drugs like acetaminophen, isoniazid, and phenytoin. Ischemia, hypertension, vascular outflow obstructions, and metabolic disorders like Wilson's disease, and pregnancy, if it is there, acute fatty liver of pregnancy also has to be considered. So jaundice and fever, it's basically when the fever precedes.
Just go to the previous slide. Now what will happen in the exam, the students will read this and they'll give all these differentials. What is the subacute hepatocellular injury and what is chronic hepatocellular disease?
Subacute is...
all this will go on Facebook. They'll read this and they'll start answering in the exam.
The subacute
is... first thing they'll say celiac disease. Dr. Vici.
Pardon?
Just tell them, no? What is the subacute hepatocellular injury? I've never heard
This
of this.
subacute hepatic failure business was there for liver failure. It was we had confusion between chronic liver disease, acute liver failure, and decompensated disease in a chronic liver disease. And there's an entity called subacute hepatic failure, which was initially described from India, and it's no more considered as a standard definition. And there are many Western people who do not accept this entity at all. Okay, now the confusion has got cleared because acute liver failure can be from day 1 to 6 months. So the confusion is over. Anything occurring after 6 months is chronic liver disease. The confusion is now completely over. I think it is not acute presentation or a sort of insidious presentation may be a better term. An acute presentation, okay, that means within a short period of time, or when the patient is not very sure of the onset. And then it has probably evolved over a period of maybe 2 weeks or 1 month. And the jaundice has been there for the illness has been there for more than 6 months. Then only you can definitely call it chronic hepatocellular. And chronic for cholestatic is 3 months. For hepatocellular, it is 6 months. Okay.
And what you're actually mixing up is the histology, chronic hepatocellular disease is not chronic liver disease. Are you understanding? Acute or subacute hepatocellular injury, you're talking of the injury to the liver. We are talking of clinical medicine. Are you understanding? Be careful. Yeah. Be very careful. Yeah. You're not talking of what's happening in the liver.
Okay. Next one. Jaundice with fever. Now, Priyanush, can you go back, Ravanga?
Yes.
Priyanush, can you tell us the condition where you have got jaundice with fever?
So, jaundice with fever can. Am I audible, sir? Hello.
You are audible.
Yes, sir. So, jaundice with fever can be seen in cholangitis, sir, cholecystitis, sir. If there is some
we described acute hepatitis, no?
Acute hepatitis
of different etiology, the most common still being viral hepatitis.
Viral hepatitis.
Yeah? Okay.
Yes, sir. Some drugs, drug induced.
Agreed. Alcohol.
Toxins, drug induced, sir.
Okay. Then you said about cholangitis. Anything
cholangitis,
else?
sir.
Anything else?
Sepsis also can cause it, sir.
Means the septicemia with jaundice.
Yes, sir.
Okay. Anything else?
Name all the infections. Name all the infections.
Malaria can have.
Okay. First concentrate on liver, then we'll go out of the liver. Okay. Yes. What about abscess? Pyogenic abscess?
Pyogenic liver abscesses. Pyogenic abscesses.
So pyogenic liver abscesses. Okay. And then extrahepatic causes for fever and jaundice. What are those?
So there can be the cause for the cholangitis. Maybe if there's a choledocolithiasis, sir.
No, I am asking you. Not extrahepatic means completely out of liver. I am not considering extrahepatic biliary obstruction. Non-hepatic causes of fever and jaundice.
The sclerosing cholangitis, sir.
No, the liver is not the primary disease. The disease is elsewhere, a systemic illness like malaria, leptospirosis.
Malaria, infective causes.
And sometimes, of course, liver can be affected in typhoid hepatitis, paratyphoid hepatitis.
Yes,
dengue, typhus and dengue fever.
Dengue, yes.
Scrub typhus, dengue fever, leptospirosis, malaria, all this.
So, in a tropical country, we should also consider infections and other situations where we can have fever with jaundice. Yes, okay, apart from liver disease or biliary disease. Okay, that is what we want to impress upon.
Yes.
Okay. And in leptospirosis, there is a clinical clue that they will have extremely severe body ache. So the body ache will be usually very out of proportion to the degree of febrile illness. Okay. So body ache will be, and then they have other features. Can we proceed, Dr. Revanka?
Yes, sir. Jaundice and fever. Whenever there is a fever precedes the jaundice, one of the important differentials will be a viral hepatitis and drug-induced hepatitis. Whereas when there is a jaundice precedes the fever, cholangitis either due to the duct stone or a traumatic strictures can be one of the possibility. So fever with chills, if there is a persistent fever and the jaundice, we need to keep in mind the suppurative cholangitis, malaria, Weil's disease. In Weil's disease, the occupation history makes them a paramount important. The patient might be a farmer, specifically paddy field, and the sewage workers will be in a higher risk, and septicemia and multiple pyogenic abscesses and others like dengue and other infections. So other important things we need to ask is history of a high risk sexual practices. That is a very important in case of hepatitis B, and special risk factor for hepatitis A are the travel to the endemic areas and ingestion of the raw shellfish that is harvested from contaminated waters. In this patient, on examination, patient pulse rate was 96 beats per minute, BP was 110/70 mmHg, pallor was absent, icterus was present, no lymphadenopathy, no scratch marks. Systemic examination per abdomen showed a mild tender hepatomegaly. Few things to be looked for is a KF ring. Ideally, it has to be seen in the slit lamp, but per abdominal examination in fluid is present or not. CNS, confusion, flaps, specifically if you are suspecting a fulminant hepatitis, and tremors and dystonia if you are suspecting a Wilson's disease. So in a case of in a acute liver injury, there will be the hepatocyte damage will be there, that resulting in the both conjugated and hyperconjugated bilirubin to reflux into the blood, as well as the AST ALT also will be elevated simultaneously. So CBC, these are the blood investigation which was found. The WBC was 12,000, and the other than that, the total bilirubin was 6.2, direct bilirubin was 4.8, AST was 300, ALT was 850, whereas alkaline phosphatase was normal, INR was 1. The USG showed a mild hepatomegaly, and the viral markers, the IgM anti-HAV was positive.
Which are the situations you get an extremely high transaminases value? Like 10,000.
One is viral hepatitis, sir. One is in toxin induced. Basically, toxin induced will have a very high enzymes. Paracetamol toxins.
Keeping in mind.
Paracetamol, rat poison, both can present with a high enzymes.
Then
Ischemic hepatitis.
HSV and ischemic hepatopathy.
Ischemic hepatitis will have more of AST more compared to the
hepatopathy.
And herpes.
HSV.
Okay.
This is a case of hepatitis C. So the case 3, 44.
Priyanush, you continue the discussion. Okay.
Yes, sir.
Priyanush,
yes, sir. A 45-year-old female.
Previous slide. How do you manage?
This case, ma'am, it's a.
Just tell a few words on adult HIV.
Adult HIV, ma'am, it is most of the time it will be a self-limiting. The idea, only thing is two important red flag signs are, one is confusion and one is altered sensorium, which are important to look for a.
What is? I'm very specific about it. HIV versus HIV.
HIV.
Should I be more worried about HIV or HIV in an adult?
HIV is more dangerous, ma'am. They were high risk.
Adult in HIV is more dangerous or HIV?
Is there any sexual predilection for the risk for hepatitis E?
HIV is more common in females pregnant specifically.
Because it is more common, the complications are more common, like acute
common in HIV.
And morbidity.
What is HIV? HIV in an adult?
HIV is more.
How does it differ from HIV in a child?
A child, it will be.
Okay.
They might have a relapsing.
What is the most common type of presentation of acute viral hepatitis A in the community? In the community, it is called anictic viral hepatitis. They have totally non-specific symptoms, little bit nausea, vomiting, etc. People even think that it is acute gastritis because we don't do any test. It will be complete. So this is called acute anictic hepatitis, which does not come in the diagnosis of hepatitis at all, unless you do LFT, etc. for that particular illness. Okay, so that's the most common, and that is the most common type of presentation in the community. Okay. That symptomatic hepatitis is the one which the patients come with prodromal symptoms and jaundice. And third group of presentation is the one with complication. What are the complications of acute viral hepatitis A?
Why are we talking so much about A in an adult? Dr. VT just mentioned, no, it's in the college. They don't have any basic immunity. So they mount a huge immune response. A in an adult, they're always worried. It goes for 6 months, 9 months. We sometimes even resort to steroids. They can even develop ascites. You must please read about HIV in an adult. They are totally different. They're always worried if a person is HIV IgM positive because it will continue for 6 to 8 months. It doesn't take the usual natural course. If it takes, we are lucky. Whereas E usually comes 4 to 6 weeks and subsides, but A in an adult behaves totally differently. Okay. Okay, please read about HIV adult.
And they can also go into what is known as a cholestatic phase.
Yeah, cholestatic, and
Around
sometimes they do well with steroid.
Yeah, cholestatic phase, acute viral hepatitis, and usually once they go into cholestatic phase, the illness will be prolonged. Illness will be quite prolonged. It takes a lot of time to settle down.
And
Okay.
this is one hepatitis where steroids can be given for washout.
Okay.
So please read HIV adult. Treatment is only supportive. And
Next.
also read HIV in pregnancy.
Yeah. The difference is that in females, hepatitis E can be dangerous. So in females, especially when they are pregnant, you have to be very careful when they have acute hepatitis E.
And E can have a recurrence, okay?
Okay.
E can have a recurrence, not A.
Okay,
Please-
next slide, please.
Please read difference between A.
Okay.
Okay, continue.
And this is a case 3 where a 45-year-old female was referred by a dermatologist in view of a generalized pruritus for 2 years, aggravated since last 2 months. She gives a history of a disturbed sleep since last 2 months and a yellowish discoloration of the eyes and urine for 1 month with a light colored stool.
So who is discussing? Sumuk is there?
Yes, sir.
Okay. What do you think? What all additional question you should ask? So basically 45-year-old female referred by dermatologist with generalized pruritus for 2 years. So that's the problem. So long-standing generalized pruritus and jaundice detected since last 2 months or so. Okay.
Yes, sir. Associated abdominal pain, abdominal distension, swelling of lower limbs, then fever.
No, you should have the answer for each of your question. Why are you asking for abdominal pain?
Abdominal pain if patient has recently developed cholangitis.
Do you think this patient will have abdominal pain, progressive pruritus, and jaundice?
Okay, 2 years dominant symptom was only pruritus. Okay, and
Yes.
what you are probably aiming is to know whether there's a choledocholithiasis. But
Yes.
Charcot's diet is classically called intermittent jaundice. Intermittent. So the symptoms are intermittent. It is not persistent. That's the most important thing about choledocholithiasis. Okay.
Yes,
So
sir.
the long history of 2 years and no symptoms and recently developing jaundice. That is what has to be in your mind.
Yes, sir. Then we abdominal.
Okay. One will have to ask all these questions. Abdominal pain, agreed. Then
abdominal distension, swelling of lower limbs.
okay, to know whether there are features of liver disease, chronic
Decompensation of chronic liver.
decompensation. Agreed.
What are you thinking in your mind when you're asking for ascites and edema leg?
Patient with a previous female, middle-aged female with previous history of pruritus. Now
Not
present,
previous, it's ongoing.
ongoing history of pruritus now presented autoimmune hepatitis and primary biliary cholangitis.
Autoimmune.
Right.
No,
Autoimmune.
that is a dangerous answer.
That is the most dangerous answer.
Because AIH seldom ever presents with pruritus unless it's a sort of combination. Okay. It's not, that's not the presentation of autoimmune hepatitis. Presenting with pruritus.
Right.
When can you get secondary biliary cirrhosis? When the person has, say, post-cholecystectomy secondary biliary cirrhosis, then they can develop ascites and edema leg. Even primary sclerosing cholangitis seldom present with ascites. It's not common.
Okay.
Secondary biliary cirrhosis can go in for decompensation.
Is GI bleed important?
GI bleed?
Yes. In this. Yes, sir. In this patient, upper GI is because there is a recent onset yellowish discoloration of eyes since 1 month. So
the relevance actually, if the person had EHPVO and if the patient had multiple episodes of GI bleed in the past, had some endotherapy, and patient remained very well until 45 years ago, and then started developing pruritus, then jaundice. What is the problem then?
sorry, sir, I didn't get certain.
Patient has recurrent upper GI bleed in the past and has now come with pruritus with jaundice. What are the possibilities? EHPV.
Portal carcinoma associated cholangiopathy.
ECC.
Okay.
Yes, sir.
Yeah. So the GA bleed, that's how it becomes relevant. Remember that it's a long history of pruritus. Long means at least 2 years with no
Yes,
other
sir.
symptoms in between. Okay. So the process has been insidious in onset. It's not all of a sudden. Then insidious onset, what all things can occur? A stricture can develop. Okay.
Yes, sir.
Stricture due to various things, no?
Yes, sir.
Okay, proceed.
So this is a case presenting with pruritus, jaundice, and a clay color stools. The excessive bile salts in the serum releases the histamine from the mast cell, resulting in the pruritus symptom. So this is a case of a cholestatic jaundice, and cholestasis is the impaired formation of the bile or a flow of the bile. So it can be intrahepatic or extrahepatic. The few of the symptoms which will guide symptom and sign which will guide us for the extrahepatic are abdominal pain, features of cholangitis, prior endoscopic therapies, evidence of metastatic carcinomas like lymphadenopathies, weight loss, and a palpable gallbladder or upper abdominal mass. If coming to the abdominal pain, the main classical abdominal pains are one is biliary colic, where there will be episodic epigastric right upper quadrant pain lasting for less than 6 hours and aggravates on the food intake, which is specifically seen in the gallstone diseases. And in a patient with a continuous epigastric pain and radiating to the back, it is more of a pancreatic pain, which can be seen in a chronic pancreatitis and pancreatic malignancies. Specifically,
Why is it called a colic? Biliary colic?
Ma'am, it's a hollow tube. Basically, because of a hollow tube, there will be a intermittent type of an pain. It will come and it will relieve, and then again it will start.
What's the difference? Why? There's always a problem, no? Why? How does it differ from a ureteric colic?
This is associated with every time with the more of food intake, ma'am. Actually, because
Really, gallstone pain is associated with food intake. Huh? Who said that?
How it differs from ureteric colic? That was ma'am's question. Actually, your textbook says very clearly, biliary colic is a misnomer.
Misnomer. Why is it a misnomer?
It's a steady pain it relieves within 6 hours.
What happens to ureteric colic?
That it will be more of intermittent colicky pain, which will be present.
This also intermittent colicky. It will not touch the baseline.
Okay.
If you draw, they'll ask you to draw the graph. In a biliary colic, it will have a steady rise, last for 4 to 6 hours, but it will not touch the baseline. The patient will have a dull, lurking pain. It is a ureteric colic. It's a sharp pain, upright. It goes right up and comes down, touches the baseline, and patient is symptom-free, only to get the next pain again. So that's a misnomer. All what you said, hollow tube and all, they agree. But when you draw the graph, if you see appendicular pain, they will have 3 of these graphs: appendicular pain, gallstone pain, and ureteric colic. These are all in our old lesson. I do not know whether it's there now. That's a major difference.
Okay. So if we come to the differentials here, the intrahepatic cholestasis and the extrahepatic, basically intrahepatic can be seen at the bile canalicular region, or it can be at the interlobular bile ductular region or cholangiocyte, which is lined by interlobular bile ductular, which is lined by a cholangiocyte, which can be seen either because of an as you can see here, black. There's basically infiltrative disorders like sarcoidosis, tuberculosis, PBCs. These patients will have the more of interlobular bile ductular region involvement, and viruses, alcohol, drug, and septicemia, they are mainly in the bile canalicular region.
Where is alkaline phosphatase produced?
Ma'am, they are produced by cholangiocyte.
Cholangiocyte, where?
Effective.
Where? Canalicular where? Cuboidal epithelium, ciliated. It's with the alkaline phosphatase. And where's gamma GT produced? Because you keep asking for alphas and gamma GT. No? So in all these small lesions, all these sarcoidosis, tuberculosis, HCCs, they all, once they are around the canaliculus, they trigger the secretions of the alkaline phosphatase from the cuboidal epithelium that is lining the canaliculus. Gamma GT is produced both in the hepatocyte as well as the cuboidal epithelium. So there are 2 sites for gamma GT. Okay, continue.
Whereas PSC, that is primary sclerosing cholangitis and secondary sclerosing cholangitis, and IgG4 can involve both interlobular bile ductule as well as the extrahepatic ducts. Extrahepatic cholestasis is basically a bile duct stones or a neoplasm. Lymph nodes can in and around the bile duct can eccentrically compress, and the strictures and some of the strictures can be because of HIV cholangiopathies, or it can be because of cholangiocarcinoma. Portal hypertensive cholangiopathy is also one of the differentials.
Don't forget the worms. Which are the worms? Which are the worms that can, in the lumen, that can present with? Cholangitis.
Ascariasis, biliary ascariasis.
Who has written maximum papers on biliary
Describe the
ascariasis?
entity in India.
In India?
We have mentioned the name earlier.
No, don't say AIMS. Or don't
Today we
say
have
CMC,
mentioned the name
don't say
earlier.
CMC Vellore.
Dr. Kuru,
Shere Kashmir.
Kashmir again. Okay. Now, suddenly they may ask you, what are the other parasites?
No, which are the other parasites? Yeah, which are the parasites that? Pistiopus viverni.
Parasites of liver.
Clonorchis sinensis, hydatidosis, the rupture, roundworm infestation.
Roundworm, fasciola, hepatica, clonorchis, sinensis, bilharziasis, because schistosoma also. Yeah. Schistosoma hydatid. So be ready for a short question for parasites affecting the liver or portal venous system. Okay. Next.
Some of the important things like color of the urine.
Just go back. Don't miss AIDS-related cholangiopathy, IgG4 cholangiopathy. Okay, that's often we often miss those two because it doesn't fit in anywhere. But long-standing, don't forget AIDS-related cholangiopathy as well as IgG4.
Yes.
Yeah, PSC, IgG4, AIDS, cholangiopathy. There may not be much clues.
You won't have much clues at all. But be aware of these differentials.
Okay.
And Lemmel's, what is Lemmel's diverticulum?
Periampulary diverticulum causing an obstructive jaundice type of picture, the LFT.
How does it cause?
It causes compression of the common bile duct.
How? Why should a diverticulum cause compression of the CBD? When food enters and it's not emptying, then the food bolus that is there in the diverticulum causes compression. The simple diverticulum will not cause compression. No?
Yes, ma'am.
No, it's only when it is laden with food and it compresses the distal CBD.
Yes, ma'am.
Okay, continue.
So when coming to the color of the stool, the light color or clay color stool, which is seen in the obstructive jaundice or cholestatic liver disease, bulky and oily stool, it's not a color. It's basically, it is seen in a cholestatic liver disease basically because the bile salts are required for a fat absorption, and which results in a fat malabsorption resulting in a steatorrhea. And melanic stools are seen in a carcinoma of the ampulla of Veiter or hemophilia, and silvery stool, which is a combination of the clay color stool with the blood, which is seen in the carcinoma of the ampulla of Veiter.
The other important thing is one. You don't use the word clay, use the word pale, P-A-L-E.
Yeah.
Because clay
pale
is China
stools.
clay. Clay is China clay. The China clay is the clay, the color that you use in tiles, you know. That is China clay. Whereas the true clay is actually the slate colored clay.
Pale.
So best is just use the word pale.
The clay has a different color in different parts
of the world. Exactly.
Yeah, that's it. So pale stools. That's
just a simple word, pale stool. Now, what is the importance of doing a urine urobilinogen in patient with jaundice?
Ma'am,
acute viral hepatitis. What will happen to the urobilinogen?
Urobilinogen will be elevated, ma'am.
Cholestatic phase?
Cholestatic, if it is partial, then it might, but complete, it will not be elevated.
Elevated, huh? So
not elevated in cholestatic, ma'am.
Just tell me appearance, disappearance, and reappearance in acute hepatitis.
In acute hepatitis, initial phase,
it will be present, absent in cholestatic.
Absent in cholestatic.
So it is a good prognostic simple test which will tell you the patient is responding. So disappearance and reappearance of urobilinogen. Is urobilinogen normally present in urine?
Yes, ma'am. Yeah.
No doubt. You have a doubt. Is it present or absent?
It will be present, ma'am. Actually,
Why should it be present?
enterohepatic circulation will be there, and with the colonic bacteria will cleave the stercobilinogen and
So urobilinogen is normally present. Remember that. Only thing, it becomes plus in acute hepatitis, disappears during cholestatic phase completely because bilirubin is not being transferred to MRP2, and then reappearance. So reappearance is a sign of just a simple test tell you the patient is doing well. Okay, continue.
So some of the important history which has to be asked in a cholestatic jaundice. One is as a gender basis, the females are more predominantly PBC is more predominant in females, and primary sclerosing cholangitis is more commonly seen in the males. History of a drug intake and a CAM intake is another important history. History of a joint pain, redness of the eyes can give some clue towards autoimmune, basically in the IgG4 disease. History of a steatorrhea, loose stools, and a blood in the stool. Steatorrhea is basically cholestasis, and loose stools and blood in stools is basically associated PSC and the ulcerative colitis.
In cholestatic jaundice, you not get steatorrhea. Okay. What percentage of patient obstructive jaundice have you ever got patient with this thing? Would you ever get that?
Okay.
Yeah, I also agree. Steatorrhea is not an important presentation. Theoretically, it may happen when you provoke the patient with the 72 or fat test, etc. Steatorrhea may be detected, but clinically they are seldom present with that complaint.
None of the obstructive jaundice is present with a fatty stool. That is all only, as Sir said, more of a examination. Yeah, it is biochemistry, biochemical tests. So don't say steatorrhea. Don't say no history of steatorrhea in a case with jaundice.
History of a evening rise of temperature, cough, or a wheeze, it gives a more clue towards the patient of tuberculosis resulting in infiltrative disorders. Jaundice occurring in a seriously ill hospitalized patient is often caused by either a sepsis or a shock or a drug. If a patient is having a previous history of malignancy, definitely a hepatic metastasis has to be ruled out. In a patient of a pregnancy, intrahepatic cholestasis is one of the differentials. If a patient is having a joint pain and the joint swelling, the autoimmune or viral hepatitis, hemochromatosis, PSC, and the sarcoidosis to be one of the differentials. So, as the cholesterol ADEK, the vitamins are basically fat-soluble vitamins. They are their absorption also will be reduced. So, these are the histories which has to be asked. These are night blindness to see whether patient is having a vitamin A deficiency, thick skin or a toad-like skin, which is seen in phrenoderma, which is a vitamin A deficiency. Symptoms of coagulopathy like easy bruisability or a bleeding, tarry or a bloody stools. Kyphoscoliosis, fracture because of vitamin D deficiencies, and peripheral neuropathy in the form of either a patient will have a cerebellar ataxia or a peripheral neuropathy symptoms might be present. And loss of height or a back pain is again a hepatic osteoarthropathy secondary to the vitamin D deficiency.
So you look for all your xanthelasmas, no?
Yes, ma'am. This I will come to the clinical.
But other important thing is you should know which of these are normally. Don't say night blindness. You say adaptation to light.
Okay, ma'am.
Yeah, time taken. That is what Dr. Vichi's favorite question. What do you mean by night blindness? Is the time taken for adaptation to the dark light. Time taken. Okay, and most of the things you never get, the bruising, all this. So they'll ask you, vitamin E is the last deficiency. So all your symptoms and all will never happen. So be very careful. You should know which of the vitamins will manifest first, what duration of jaundice will cause deficiencies, all this you should know.
Okay.
Which is the one which is most likely to be showing the effect first?
Earliest.
Coagulopathy.
A, K or D?
K might be the
possible.
Vitamin D.
Okay, next.
So the past history wise, we need to know whether a patient is having a gallstones or any history of hepatitis, inflammatory bowel diseases like specifically ulcerative colitis, infiltrative disorders in that the sarcoidosis, amyloidosis, lymphoma, or history of tuberculosis. Similar episode of a jaundice which can be seen in the brick, and HIV infections or AIDS also because of HIV cholangiopathy has to be ruled out. Previous surgery on the biliary tract causes a stricture, and hematopoietic cell transplantation because something called as graft versus host reaction that can also present with a cholestatic jaundice.
So when you're presenting, don't keep on saying no history, no history. Don't say no history of gallstone, no history of intermittent bowel disease, no history of this. Don't say the way you describe. Don't have too many no histories. Focus on the case and relevant to that, mention no histories, okay?
Okay.
Because if the patient has hematopoietic cell transplantation, it will already come in your presentation. It's not going to come as a surprise to you.
Okay.
And if the patient gives history of surgery, that again, so just be very careful. Don't have so many no histories.
Okay.
Relevant to the case. For example, this particular case with pruritus that you mentioned, none of them are relevant. All this should be in your mind, but you'll not put it across as no history.
Okay, go ahead.
On examination, patient had a pallor. Patient pallor is absent. Icterus was present, which is the icterus. No lymphadenopathy. Systemic examination showed no palpable mass as such in the this right hypochondrium, and the patient had a more of a xanthelasma in the xanthomas in near perioral areas, and the scratch marks were present.
You expect a mass in this patient, huh?
No, ma'am. Like just to tell that the one of the thing which you have to see in a patient with the
in this patient with pruritus for 2 years, itching.
No, ma'am. I will not expect mass in the here.
No, when you say palpable mass, it looks as mass anywhere in the abdomen. It's not like that. What you have to say here is most important. We said biliary cirrhosis. Mention the liver. Mention spleen. By now, you expected cirrhosis to settle in case of secondary biliary, and then say gallbladder is not palpable. Simple. Don't say masses. It will be very simple and plain. No, just say liver is palpable so many centimeters. Spleen is this, and gallbladder is not palpable, and no ascites.
Okay. These are the few things which we have to look for in a patient with a cholestatic jaundice. One is, as I explained, ADAK deficiencies like purpurias or new signs of primary tumors like lymphadenopathies in the virtuous lymph nodes or a Sister Mary Joseph lymph nodes has to be seen. In a patient with the cholestasis, we need to look for a 2-year. We need to look for ascites, history of there is any dilated veins or any stigma of chronic liver diseases to rule out as primary biliary, the secondary, the biliary cirrhosis. And other than that, the jugular venous distension in a hepatic congestion can be seen, K-ring in the Wilson's disease, and migratory thrombophlebitis can be seen in the CA head of the pancreas. These are some of the things which we have to look for a cholestasis. And
then mention about the Trousler sign, Irish lymph nodes, signs of primary tumor. Virchow nodes?
Virchow nodes, ma'am. Virchow nodes are seen in
thrombophlebitis. Okay.
Is it a node? Is there again a misnomer there? What is this Virchow node?
Left.
Dr. GC's favorite question about gastro. It's actually just a subcutaneous fat, no?
Infiltrated subcutaneous fat.
And actually, so thoracic duct, which throws its tentacles around the subcutaneous fat, the tumor gets regurgitated, and that presents as a lump there, as Virchow's node. It's not a true node. It's not a lymph node.
Okay.
You should know this mechanism. What happens in CA stomach, CA pancreas, where it's actually regurgitation of the metastatic deposit there into the thoracic duct. The regurgitation is one presence as a mass. Continue. Over. Can you stop?
Next is few abdominal examination. The enlarged tender nodes where viral alcoholic hepatitis and infiltrative diseases we can see. Shrunken can be seen in cirrhosis and fulminant hepatic failure. Abdominal examination, few things to be seen is marked splenomegaly. If it is there, the cirrhosis with portal hypertension risk is highly, and some lymphoproliferative diseases like lymphomas can present with marked splenomegaly, and hard and nodular hepatomegaly, a metastatic malignancy.
Massive splenomegaly is not a feature of lymphoma. Massive splenomegaly have a separate group of diseases: mild splenomegaly, moderate, and severe. That's a classic classification, and accordingly, very large spleen is mostly of hemopoietic malignancy, myelofibrosis, all those things.
CML. Yes, sir. CML.
But lymphoma, I don't think is a major cause. It is a mild to moderate splenomegaly. CML, myeloproliferative disease, all those things produce significant hepatomegaly, malaria, all those things. Okay. Here is a leukemia. Okay.
Few things like ascites plus jaundice if it is present, cirrhosis, malignancy, tuberculosis, and acute pancreatitis has to be kept in as a differential. Gray Turner sign can seen in acute pancreatitis, Murphy's sign in cholecystitis and ascending cholangitis, and other abdominal masses like primary CA of the stomach and colon has to be seen.
What is the Murphy's point?
In the right hypochondriac pain.
What is the anatomical landmark?
Ninth rib, ma'am. In the mid clavicular line.
Mid clavicular. You're right. Are you right? What is the Murphy's point? How do you get the Murphy's point? Is the rectus abdominis with the ninth costal cartilage where it intersects. How can you get that point? One is that's one landmark. Other one is draw a line from the left anterior superior leg spine, which touches the ninth costal cartilage. That is the other point, Murphy's point.
What is Murphy's sign?
That is the rebound tenderness which we see when a patient is palpated in that particular spot.
So you touch and then press and release, like in appendicitis? No, it's an inspiratory catch.
Inspiration.
Yeah, it's an inspiratory catch felt in that point. Okay. So, okay, you have to know because these are basic things which we all learn in MBBS, especially third year. So if you make mistakes in basic things, examiners will get cut up with you. Okay, that is sometimes we would have done all wonderfully, the case wonderfully well, but some major basic mistakes you make, and some of the examiners actually do not tolerate basic mistakes. Just they don't tolerate it at all. They say that you are doing second level PG and still do not know the basic. That is their approach. No, we can't find fault because the basic knowledge. No, so the basic things you have to be absolutely thorough. Okay, go ahead.
And this is especially when the case is difficult. Then we come down to know whether you're strong in your basic. That's exactly what happens. Finished, huh?
No.
This is an investigation which was the total bilirubin was 6.2, direct bilirubin 4.8, alkaline phosphatase was elevated 421, and USG showed a normal liver texture and no HBLD. AMA was positive in this patient, and other serologic markers were negative.
What is SGG? This is the same patient, pruritus, no? So how do you explain AMA?
Yes, ma'am.
So how do you explain that? PVC present with this thing, no? Pruritus, no? PVC present with pruritus?
Yes, ma'am.
Or is it the PSC? PVC present is fatigue. PVC present is fatigue, exhaustion, tiredness, and then you start doing, then you find AMA being positive. Just much later, no? PVC, we have not seen so many. Most of PVC is present more of fatigue, exhaustion, tiredness, and then you find these enzymes going up, and then you do see them IgG, which is elevated, and then AMA is positive. It will be an overlap. It will be an overlap with PVC and PSC, this patient.
Okay.
So in these patients, ultrasound will help, and if there is a dilated bile ducts, we need to further investigate with the CT, MRCP, ARCP. If there is an intrahepatic cholestasis, then the serological studies like AMA, hepatitis serology,
serum IgG will be the first one.
IgG.
Serum IgG.
So AMA is positive, then the liver biopsy will help to aid.
I think we'll stop there.
Okay, it is 9:30.
Yeah, it will be too much. Yeah. Let's not move to extrahepatic is a huge chart. Extrahepatic is totally different.
Yeah, I think because approach to jaundice, extrahepatic we will cover.
Next time.
We will cover it in usual case discussion.
Yeah.
And any further comments you want to make, ma'am?
I've made all my comments.
Okay.
And that's quite
so, I think intrahepatic cholestasis is the difference between intrahepatic and extrahepatic at bedside history taking on physical examination on investigation. Okay, the usual line of investigations for liver disease is basically simple. It can be simply guessed because the routine test, liver biochemistry, serology, specific test, imaging, ultrasound, CT/MR, etc. So there are some examiners actually who do not give any marks for telling the investigation because it's a simple thing. But how you interpret the investigation, that is most important. So you must be able to interpret the different abnormalities seen, and you must be able to do it confidently. That is what will be appreciated. Okay, Revankar, I think we will finish here. And thank you very much.
Any questions in the chat box? I think none. There are no questions in chat box.
Chat box questions.
There are no questions. There are no questions.
Mm.
Any the three of you just presented now. Any questions you have, you can just ask.
Yeah, all the 3 persons who presented,
Can you just
Ravanga
any
can ask
doubts you have?
questions.
Yeah, any doubts you
Sumit
have?
can ask questions.
Up to here.
Priyanush can ask questions.
We are not
Each
touching
is-
extrahepatic. Within these cases that we discussed, you can just ask if you have any doubts.
Sir, what's the duration of jaundice in intrahepatic cholestasis for vitamin D deficiency to manifest?
It will take at least 2-3 months, no? It will not be that fast. E takes 6 months. A may be the earliest.
Yeah, maybe within 2 weeks.
Yeah, because D storage is there, no? So D
Yeah,
is
D
much,
is
much
very
later.
late. D also 3 months.
Yeah.
3 to 6 months period.
E is the last. K is the first. Any other questions?
question?
So just brush up all this, okay? One is clinical presentation. The first one I asked is a ward round. The patient comes to you with jaundice. That's a ward round. Okay? Thank you.
Okay, thank you, Dr. Ravanga. Thank you very much for your presentation.
Nice presentation.
I think
Good
this is a very
discussion.
nice presentation. You have covered a lot. You have taken pains to include a lot of cases. I know you have 2 more cases, but then we kept on with the discussion because each point you have to learn it thoroughly. Okay, so it was a very good presentation, and I also thank Sumit Priyanush for joining us at a
Thank you,
short
sir.
notice
Thank you, ma'am.
for the
Thank you,
discussion.
sir. Thank
And
you,
I thank
you, sir.
Clarinet. And now I invite Dr. Jerry, our coordinator, to say what to thanks officially.
Thank you, sir. On behalf of residents, I would extend our sincere gratitude to Jayanti Ma'am and Vogi Thomas sir for coordinating today's case discussion. I also thank Kiran for the wonderful presentation. I also thank the ISG Kerala for organizing such a wonderful platform for learning purpose for the residents. I also thank the academic partners, Clarinet, for supporting us through this presentation. Thank you.
Thank you, Vijay. Good night.
Thank you. Bye.
Bye. Good
We'll
night.
see you at the ISG, no? You are there.
I'm leaving tomorrow.
I am also.
Okay. We'll
We
catch
will
up
not meet
tomorrow
there.
night. Tomorrow night we'll catch up. Yeah. Okay.
Yeah.
It's very cold, no? Red alert.
Yeah, very cold. Daytime it's 17, night it's 10 o'clock. 10 degrees centigrade, 10 or 11.
10 or 11.
So
Okay.
it's well prepared.
Okay. Bye.
Well,
Good night. Good night.
Good night.
Good night.
Good night, ma'am.
Sir, next week, our schedule should be a case or topic.
If you're, I think if you have a jaundice case, we can take it. Otherwise, we'll continue with the topic discussions.
Okay.
Okay. If you have a topic ready, we'll finish it off and then gradually take it. Okay. So can we close today's session?
Sure.
Okay, I have to stop because okay. Okay, then good night. Jerry, we will discuss later. Okay, good night, all of you.